Before we get started in this episode, a quick announcement. As you know, I'm very passionate about acceptance and commitment therapy, and I also run a busy practice in Canberra. We're currently looking for psychologists who are registered in Australia to join our team, who are also passionate about learning about ACT. We provide supervision on a group and individual basis and training around ACT. So if this is you, if you're interested, please express your interest at strategicpsychology.com.au/careers. Look forward to hearing from you. And now back to this episode.
Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking. Yeah, better thinking. Time to tune in. Let's go.
Welcome back to Better Thinking. My name is Nesh Nikolic, and today's guest is Dr. Alan Davis, who is an assistant professor of social work at the Ohio State University and an adjunct assistant professor in Psychedelic Research Unit at Johns Hopkins University. Dr. Davis's clinical experience includes working with people diagnosed with trauma-based psychological problems such as addiction, PTSD, depression, and anxiety, and his clinical expertise includes providing evidence-based treatments such as motivational interviewing, cognitive behavior therapy, acceptance and commitment therapy, and psilocybin-assisted psychotherapy. The reason why I've asked Dr. Davis to come on the show today is he has a tremendous interest in why do evidence-based psychotherapies fail, particularly in the drug and alcohol treatment space. And he's looked at how we can go and improve them. One of the introductions that he brings into this space, along with many others, is psilocybin-assisted psychotherapy. And there's some really interesting insights that come from this research and how therapy can be improved or enhanced by assisting, I suppose, gateways of perspective that make psychotherapy a little bit more robust. Please welcome Dr. Alan Davis to bring this forward as a not necessarily a new concept, but certainly as a new consideration in therapy that still needs to be researched somewhere further, although there is some promising science. Enjoy the show. Dr. Alan Davis, a big thank you and welcome to the show.
Thank you so much for having me. Delighted to be here.
Look, I'm really excited to get straight into this conversation with you, in particular around this interest of yours. And I know that you've been intrigued by it in terms of why does psychotherapy sometimes fail, and what are some of the things that we can do to improve it. So I might just ask you the first question of how did that even come about, that question? How did that interest show up for you?
Well, prior to going to graduate school for clinical psychology, I worked in a drug and alcohol treatment center for a number of years. And as part of that early clinical work, I saw a lot of clients who would cycle through several times coming in and out of treatment. And one of the things that I would ask my superiors at the time was, why is this? Why is it that people, leave and they come back? And usually the response I got was, well, they're not ready. There's something wrong with them. And never once did anyone say the treatment wasn't good enough. And it just didn't make sense to me, that somehow the treatment was already perfect, but it wasn't working. Didn't really make sense. And so I kind of left with that question of, why is it that the treatment's not working? And why is it that we blame the person who's in treatment?
It's fascinating that we don't talk about the limitations. It's almost like there's a bit of a blame, the client's resistant or they're not ready, they have to hit rock bottom, whatever the traditional things that people might think of, versus maybe looking at, that treatment isn't necessarily a cure. It's an aid to support someone, but doesn't necessarily achieve the results that maybe the clinician or even that the client wants. That there's challenges in there.
Absolutely. And I think it's difficult sometimes for the clinician to consider their own limitations and what they're good at and whether what they're providing is the right fit for the person that's coming in. And so I think in a lot of ways, sometimes it's easier to assume that there must be something else going on other than whether or not the treatment's working or not. And what I've seen time and time again in a lot of different clinical environments is that oftentimes clinicians have good intention. They're there to help. They want to provide the treatment the best they can. But we typically see in the research that there's not enough good fit between the types of treatments that someone has access to and the outcomes that they're looking for.
Do you mind talking us through a little bit of that research in terms of what are we looking for fit, or what is it that would be effective at different times for a client? Because obviously clients are attending at different stages in their life with different issues, difficulties, and so on. Can you talk us a little bit through the research that you've looked into?
Sure. We have looked at this in a couple of different ways, primarily starting off with this question of addiction treatment and looking at why and in what ways that treatment offering may not be the best fit for some people. And one of the things, at least here in the United States, I know it's a little bit different depending on where people are at in the world, but in the US, the primary offering for addiction treatment is an abstinence requirement, that people are only really allowed into treatment if they choose to be abstinent from the substance that they're using. And if they don't, then they're essentially kicked out of treatment, or they're told that it's not a good fit for them. But in actuality, there are lots of good options, including things like non-abstinent interventions, moderation, controlled drinking or drug use, harm reduction therapy, that can be effective in helping people learn strategies to be safe and to increase their quality of life and their overall healthy functioning. But those interventions, for whatever reason, are unacceptable overall to the clinicians and the agencies that are providing this treatment. And because of that, there's a lack of fit between what probably most people need and what they're being offered.
Is there any truth to this concept of supporting, particularly in whether it's drug or alcohol abuse, persons with removing the persecution around that space and in actual fact being a little bit more pro-social rather than chasing people down to charge them with possession of marijuana or whatever it might be, to in actual fact identify people who need support and look at more social programs around belongingness and being connected to values and interests in the community versus a more war against drugs type of scenario where we'll penalize you and you'll be an outcast from society. Is there any truth to that? I've heard that argument as being a fairly pivotal one around saying we need reform. Is that based in any research that you're aware of?
Well, we certainly have evidence from certain places around the world that have switched the model from a criminal model of drug policy to one of a public health model. And when you look at a country like Portugal, for example, that I think it's been almost 20 years now that they switched the model from one where drugs and drug users were persecuted and criminalized to one where social programs were developed and support systems were put in place to help with things like job training and integration into communities. And what you've seen in that country over the last 20 years is pretty much across every indicator of public health metric and personal well-being metric, that country is thriving in regards to their efforts in this area. And so although it's not a a typical research study, it's a really great example, I think, of what can happen when drug policy actually starts to address what it means to provide an environment for people where drug use and drug use disorders can proliferate. I think that by criminalizing these substances, we've criminalized the people that choose to use them. And as long as the criminal approach to drug policy is the predominant one, I think we'll continue to fail in terms of the types of treatments that are offered.
Can you talk us through your thoughts about why you think that model has been more successful? What are the elements that I suppose, support and lean someone to being able to, whether it's harm minimize themselves, whether it's to, have better deliberate control over or management or moderation of their use. Why are those policies so effective from your point of view?
Well, I think in part it takes a stance that we need to reconsider how we conceptualize someone who is struggling with substance use. For example, I think oftentimes we forget that the relationship that someone has with that substance is often, for a lot of people, the most secure attachment that they have in that moment. It's something that provides relief from negative affect. It's something that provides a sense of connection and belonging, oftentimes to a social group. It also provides a sense of identity for some people. These are all formative, important aspects of what it means to be human. And so when you criminalize that act and that relationship, and you disconnect that person further from society, either by putting them in jail or putting them, in a forced treatment scenario, you're essentially exacerbating the same problem that caused them likely to seek out substances to begin with. Oftentimes, people are seeking out substances for the same thing. They're looking for connection. They're looking to have a good time. They're motivated by pro-social, behaviors. And so a criminalization policy, the only thing it does is exacerbate the problem of why people are seeking this out often, and it removes from them the benefits that they're getting out of it. So, for me, it seems to make a lot of sense that when you do that, you're just creating a fertile ground for relapse. That if you don't replace that relationship with something else that's supportive and nurturing and can allow someone to grow and to connect to a supportive social group in some kind of way, then it's not surprising to me that people relapse very quickly when the penalty is removed, when they're released from jail or when they're released from treatment. And so in a place like Portugal, what they've done is they've replaced and started providing options for those things that are needed. They've provided, paid job training and connection to healthcare, and they don't remove someone from society to punish them, further exacerbating that sense of disconnection. Instead, they invite them in to community and they invite them in to participate. And often, that is a part of the way that they can help people develop more healthy attachments.
That sounds amazing. To flip it over to be, a healthcare model, to say this is someone who is in need, can be supported, and in many ways, let's get, a community approach to, assist this person to reconnect them with other aspects of the community that they might not have had during their time, or maybe they've lost over time, which is obviously a very common thing that happens with that revolving door of rehabs and the like. Is there much statistics around sort of relapse and is there data that you're aware of how likely it is for someone to go through a program and despite the best efforts and despite trying to reintegrate from an abstinence sort of space back into, community, air quotes there. Is there much data around that?
Well, the data around that type of treatment model consistently shows that the vast majority of people, I would say somewhere around 3/4 or more of people who are forced into an abstinence-only treatment will not be successful with that treatment. However, when you look at matching people to the type of treatment that might be a good fit for them, and when you look at markers that are related to non-abstinence outcomes in addition to abstinence, and if their goals are in alignment with the type of treatment that they're getting, you start to see that there are improvements in far more people when that matching occurs. So what that tells me is that we need to do a better job of offering these different options to people and helping them understand which option might be the best fit for them, at least initially when they get started in treatment, and to help clinicians best understand how to go about that matching process, and to obviously be able to provide these other types of treatments.
What do you think is getting in the way of that? Obviously, as psychologists, we're always thinking about evidence-based, approaches, whether it's in our clinical work, about whether we're using a CBT model or ACT or schema or whatever it might be that resonates for us as clinicians. What do you think is getting in the way of using a more evidence-based model of care for those with drug and alcohol abuse, dependence difficulties?
Well, I think a big part of it is stigma and thinking about the larger policy structure around how we view substances, and the differences between a model that when it focuses on the criminalization of the behavior instead of it from a public health standpoint. I think you're also then forcing clinicians and agencies into a very narrow path of considering what is evidence-based. For example, if a clinician wants to be supportive of a client who wants to pursue non-abstinence as a treatment outcome, they have to then wrestle with the fact that they're also supporting an individual with something that might be against the law. And so if that's the case, I think that creates fertile territory for there to be an ethical quandary of how to best do that. Even if the evidence base shows us that non-abstinence is a worthwhile target, that obviously conflicts with drug policy. And some clinicians that we've surveyed and asked about this, some of them say, it doesn't matter to them what the policy says, they're going to do what's best for the client. And others, bring up this issue of this inconsistency between policy and practice that really does get in the way for them, because they don't feel like there's a clear path forward for them to do that in a way that that they would feel comfortable with.
It's interesting because I've always practiced with the concept in mind, and this comes from acceptance and commitment therapy around how does someone want drugs or alcohol to feature in their life. So it's really a question of functionality, and it's I think poses a question of engaging someone around their relationship with that substance and what they want it to look like, which is really in no different way a question of how do you want your intimate relationship to look like with your partner. When we get to at least shape it, there's a question around shaping it, and within that, there's always a question of functionality, because most people don't say, look, I really genuinely want to have these major binges where it gets out of control and then I can't show up to work and then I end up becoming unreliable and I've lost 3 jobs. So I want that to repeat. I've never heard that occur, but I've certainly heard a lot of clients say, I want it to be, within the same social way as it is for those around me, so I can enjoy, a beer or a wine with them, or, maybe even having a glass or 2 while making dinner. But I do want it to in essence, kind of stop there so I can enjoy the rest of my family and I don't, become disconnected from them. And while I sit in my chair and watch television, being drunk, it's causing too many issues. So, It is interesting because functionality kind of speaks to that space of a non-abstinence based approach.
Absolutely. And part of that direction, I think, also requires the clinician and the individual who's being treated to consider those benefits, consider the positive things that they might want from perhaps a more functional relationship with alcohol or drugs, in order to figure out how they're going to get there, how they're going to achieve that goal. And I think that's something that is not well discussed in a lot of clinician circles that I've been in, is thinking about what the actual benefits are of this behavior. And there are quite a few, otherwise people wouldn't be doing it. So it's important to think about what those benefits are, and to think about this dynamic between, benefit and consequence. And sometimes the scales are going to be tipped onto one side more than the other, but they likely are still both there. And so it's essentially one of the reasons why I started looking at some of the benefits of other psychoactive drugs and the potential that they might offer to be helpful in this treatment process. Things like psychedelics that provide a benefit for a lot of people, and thinking about the ways that those unique benefits might be an advantage.
Before we jump into that space, can you talk us through a little bit about how the matching would occur in terms of what would be most beneficial for a client? What are we looking for? What are those options that are out there that makes, I suppose, an approach more sticky, if you will, that's going to have a greater therapeutic outcome than let's say potentially just your talk therapy at that time?
Well, part of that matching process, I think, involves having a conversation in the early stages of the therapeutic relationship that helps to identify what someone's goals are, and coming to determine whether or not the clinician is adequately trained to help that client meet those goals. I think the prescription, at least in the US, has often been an assumption that abstinence is the only offering. And so when something starts off with that lens, the client isn't really given the choice. They're not given the autonomy or empowerment to self-direct their own treatment. And so it must require a conversation and an openness on the part of the treatment staff or the agency to want to engage in that type of question. Not just, are you willing to do this treatment that we're going to give you, but, what treatment even do you want? What is the goal that you have? And I think by switching to a lens of self-determination and autonomy, we start to open up that type of conversation of what's actually going to be a good fit for that person. Obviously, the agency or the clinician would need to also be able to provide those options, which is another challenge in terms of implementation, and training. But I think it needs to first start with that conversation.
Yeah, wonderful. Jumping back to psychedelics, psilocybin, I'm assuming that might be one of those that you're alluding to. Can you talk us through that research? Because I have heard there be trials in that space around supporting, aiding therapy with psychedelics, in particular around drug and alcohol. Difficulties and issues that people are experiencing. What's the sort of research that's out there, and obviously that you've worked on yourself?
So there's been a number of studies at this point looking at changes that people have had with their substance use following a psychedelic experience. And we've done those studies in large-scale surveys that have involved people from all over the world who have reported that, kind of spontaneously, they had a psychedelic experience. They weren't intending for things to change with their alcohol use or their other drug use, but after the fact realized that there were changes that occurred in their use in their relationship with these other substances. And for the vast majority of the people that we've surveyed, they've reported that they've either reduced or even in some cases completely quit using alcohol, cannabis, stimulants, opioids, kind of across the substance spectrum, have seen these reductions or even complete amelioration of use following the psychedelic experience. And so what that also is paralleling is some of the research being done in clinical trials. There's been trials completed with individuals who have an alcohol use disorder, nicotine use disorder, and there's currently trials underway for folks with cocaine use, opioid use, and even a new one coming up with methamphetamine use disorder. So, and across these studies, the results are promising, showing that relapse rates are low and incredibly lower compared to other treatments out there, and the success rate of that treatment is pretty striking.
Wow. What are the researchers saying are the factors that are leading to that? I mean, I understand that psychedelic assisted sort of therapy usually has a long intake process around goal setting, what someone's wanting to achieve and get out of their I'm not sure what the even right language is, but their experience. There's obviously a consideration around how that will be guided and supporting during that experience, and then there's plenty of integration that goes on for numerous sessions after that. Is that basically how that works? It's still in line with the therapy model, and there's some specifics that people want to address, and it might not even necessarily be related to the alcohol itself. It could be related to relationships or their past grievances, traumas, so on, and it's assisted through that process, and then obviously discussed through therapy, post the experience. Is that kind of how it usually operates?
That is the general approach, is this period of preparation therapy followed by the psychedelic session. And then after that, this integration process of kind of talking about what's happened and working with behavior change and kind of moving forward. Often there are 2 or 3 psilocybin or psychedelic sessions as part of that overall package. So typically there's approximately 30 to 50 hours of therapeutic time with that individual, including those sessions with the drug. And so what's interesting is that some of the studies are also pairing, as part of the therapy, other evidence-based approaches that we know are useful. So for example, in the alcohol use disorder studies, the therapy also includes a motivational interviewing component to kind of enhance the what we already know as being kind of helpful from that modality. In the tobacco use disorder studies, they're pairing that with a CBT model and kind of looking at things like creating a target quit date and some of the other things that we know can be successful from CBT. So they're not just doing that supportive structure in some of these studies. They're really trying to take what we already know as kind of best practice and trying to see if we can augment it with adding in the psilocybin session.
30 to 50 sessions is incredible, or hours, my apologies, is incredible. That's the only sort of methodology that I see other than inpatient work is DBT programs that I think when I calculate it was almost around that 80 session mark over a 6-month period if you do 2 skills sessions and the 1 individual per week. That's an incredible amount of investment.
Absolutely. And certainly that type of investment, both on the part of the provider as well as the part of the client, must contribute to the outcome. Just having that type of commitment and willingness to go into that process. It does, depend on how many psilocybin sessions there are. If you think about it, each session is an entire day that the individual is there with their clinicians. There's usually always 2 clinicians that are working with that individual. And so that's a 8 to 10 hour a day just for the drug administration session. So if you have 2 or 3 of those right there, you're up to 25 to 30 hours of the treatment just with those.
That makes sense then. Wow, so it lasts an entire day, like in terms of prepping and administration by the time that the psilocybin begins to take effect, and then obviously needs to wear off, and well, obviously the experience wears off, and then some form of integration, I'm assuming, at that point, and support. I didn't know it took that long. That probably explains a lot of that 30 to 50 hours.
Absolutely. Yeah. And, part of that is also because in a research setting, there's a lot of the day of, there's paperwork to be filled out, and there's at least an hour to an hour and a half of just getting kind of settled in the space prior to dosing. And of course, we don't want people to leave, without, ensuring that the drug is completely worn off and getting some time to have some time to interact with the individual before heading out for the day. So usually the actual drug effects are anywhere between 4 and 6 hours, depending on the individual. But we have that extension on either side just to kind of ground the individual.
Can you talk us through a little bit of what you've seen with clients, whether it's through that experience or post, in terms of what do they report? Why is this aiding with psilocybin have so much greater affect that's seen in the research? What are clients reporting that, at least for you, stands out as improving on what we're already doing?
Well, one of the interesting features of the psilocybin experience is that it can produce these types of acute effects that often are directly relevant to addiction treatment or even depression and anxiety or trauma treatment. Often what people are reporting throughout these different trials, as well as in the survey studies that we've conducted, is that parts of their experience under the influence of psilocybin helped them see their life in a different way, helped them see their problems in a different way, that they had this insight, this psychological insight, a discovery or a new awareness about the past or the future, where they wanted to go in life. And this insight then shows up statistically in our modeling as something that is related to positive outcome. Combined with that insight experience is the mystical experience, which is one of the hallmarks of psychedelics as well, where people will have some type of spiritual or otherwise connected experience with something greater than themselves. Often it's reported as the universe. Some people report it as a experience of God or a God of their understanding. But when you combine these experiences together, these insight and mystical experiences, it's likely, a dynamic experience that is producing something that's been termed quantum change, where, something can produce a rapid and profound change in someone's behavior when you have something that's so deeply felt on a spiritual level occurring in the same experience where these new realizations about themselves are occurring.
It sort of speaks to, if I talk about it from a CBT model, it speaks to really a significant change in a belief. A new belief is formed during that experience, where there's insight, perspective around their life, their history, what's happened, and maybe some stickiness in terms of adoption of that, so that it's not just a fleeting, oh, that makes sense. There's a great insight, and then it sticks because it's got that mystical component. It must be true because I feel connected, and maybe that allows me to hold on to that new belief structure outside of the experience, so that it has some therapeutic, long-term therapeutic outcomes.
Yeah, absolutely. There's also, I think, some pretty frequent experience that involves people getting connected, seeing themselves in the context of their problem rather than kind of being fused with the identity of their problem, and other kind of acceptance and commitment therapy practices that often in ACT therapy, we're trying to create those types of experiences. But with psychedelics, they often come up as a part of the experience themselves, that you don't have to necessarily, do an activity to help someone, see this. It actually, oftentimes people report literally seeing themselves in the context of their problems, as opposed to, being right in the kind of fused with it. And then also often there's a values piece that people connect to something deeply meaningful that they realize is important to them that they've lost sight of in their life, and that somehow that becomes clearer to them in these experiences. And it really provides an opportunity for the integration therapy after the drug session day to then take hold into helping people orient their path towards these values.
It's interesting because as you're talking, I'm reflecting on how there might be some of those qualities, at least at a edge level, where, let's say, for example, someone who might be highly intoxicated might be disinhibited for a period and kind of recognize that they haven't been, maybe, I don't know, a great friend, or that they've neglected everyone while they've gone on their own, painful journey of whatever's going on for them. And friends might kind of feel like, oh my God, I think they might have, turned a corner, or there's a realization. But in the morning, there's absolutely no stickiness. There's no integration of that. Half the time they haven't even remembered. There's kind of like these potential moments of disinhibition, which might give insight, but there is clearly no connections formed. Versus genuine insight of saying, I've never seen my life from this perspective. Maybe I can see it with a more open mind, not so much with a threat or a fear. Maybe I can observe my life in a way, as an observer, so to speak. And I'm only guessing here because I obviously don't have any experience in that space, but potentially by observing one's life, seeing one's life, I can examine it without fear and potentially with curiosity, with the guidance of a therapist there, or several, and combine that with some sort of mystical experience to kind of say, wow, that actually feels meaningful, and that was something to really take note of and be valuable. And I'm going to not discard that, but in actual fact, I'm going to I can't kind of forget about it. I even if I try to forget about it, it feels so different to anything else I've experienced. So, maybe that uniqueness has got a powerful effect as well.
Yes, I think the opportunity to take that type of insight experience and to make it a productive one really does involve something that needs to happen afterwards. And these insight experiences, and even spiritual mystical experiences, they happen with some regularity for people even outside of psychedelics. These can happen spontaneously. In fact, I think in a lot of ways the whole kind of rock bottom metaphor of drug addiction treatment often includes in people's description of that rock bottom a moment of insight and a moment of often, something of a mystical quality, that something kind of, showed up differently for them in the experience, and they had a reconnection to things that were important to them for that moment. And when that's paired with people then, finding the supportive structure that they need, for some people that might be 12-step groups or some other type of peer support mechanism. For some people, that's other types of treatment. And for some, that's even self-help, and kind of working with them with their own problems in a new way. But it takes something, to afterwards to really integrate and work on that experience. Otherwise, regardless of whether it's spontaneous or whether it's psilocybin occasioned, those experiences will still be fleeting. We have some people in the studies who will have these experiences of deep insight and mystical components, and their lives don't necessarily improve. In a recent depression trial that we completed, 54% of the people in the study were in remission from depression at 1 month, which is an amazing number compared to other treatments that are out there. But that means that 46% of the people in the study weren't. And so often for those people, I think what happens is they get this experience, but they're not either able or willing to move forward in the direction that the experience highlighted for them might be more useful.
That makes a lot of sense. I had a extremely close friend, you might even call him a best friend, that died about 18 months ago. And I talk about him quite regularly in that he left me with a real genuine gift. And that was about being able to reflect on my life and ask myself, how do I want to actually live it? And, you know, that's that whole thing where we all say, you know, life is short, but for some reason, I was able to see more perspective in his death and apply that to mine. And I feel changed quite significantly personally because of it. And that's a kind of mystical sort of you know, element. Not that there was any spiritual side to it, but there was certainly an insight and great, you know, immediate integration. You know, it meant something that I can't forget. You know, it's kind of burnt into my brain around, you know, wanting to embrace the rest of life and build lots of memories. And so, and I think about it regularly, like, you know, it's with me all the time. But I've always joked with you know, colleagues and even with my friends after watching the movie Fight Club, where there's a scene where Brad Pitt, it's Brad Pitt. He, I think he grabs a stranger and he pulls out a gun, I think it is, to a stranger's head, and he says, you know, what did you want to be growing up? And I think the gentleman says, like, a veterinarian or something. He said, well, what happened? He goes, I, you know, dropped out or something. And he says, well, you know, give me a license. I know where you live. You know, go out and become a veterinarian, or I'm going to come out and, you know, come after you. And it's almost like this, you know, near-death experience changes the trajectory. Obviously, it's a bit more comical but it's almost like, you know, if we could bring a near-death experience or something that is so strong, it forces us to reflect. Certainly not suggesting we do that, because, you know, you and I both know about post-trauma and the like. But there's something there. There's a stickiness around there, and that's what I'm kind of hearing, is that some of that mystical or spiritual stuff that does happen outside of, you know, assisted type of approach like this happens every day. You know, there are lots of people around who they can pinpoint when life changed for them, and it's usually something significant happened.
Absolutely. And, you know, whether it's an accident, a trauma, or whether it's the loss of a loved one. For some people, it's the birth of a child, or someone close to them having a child. You know, these pivotal moments in life often bring about the same type of insight, or somewhat of a, you know, kind of alternative consciousness that brings about a new awakening, or a direction, or a commitment in someone's life. And so it's not surprisingly that, you know, when we ask people about, you know, how meaningful the psychedelic therapy was, or how significant it was, often they're rating it as one of the single most or top 5 meaningful and significant experiences of their lives, usually in the context of these other major life events, you know, comparing and contrasting it to the birth of a loved one, or the death of a loved one. And I think what that really highlights is that we're experiencing these shifts in consciousness and commitment to things in life in ways that I think if we could identify as they were happening and had the type of language and support to really capitalize on them, we'd probably see that overall there's benefit, there's light in all of these experiences.
Why do you think there's such great fear around this space? There's obviously a growing body of trials that are, you know, showing, you know, great therapeutic outcomes, you know, whether it's around end of life treatment, or, you know, nearing end of life, or, you know, being able to reconcile that, whether it's through trauma, addiction. Why are we so hesitant? You know, because I know even myself, if someone were to say to me, hey Nesh, you know, I can go out and do this, and it's going to be, you know, completely safe, and you'll be in good hands, I'm a bit scared of it. There's something that still makes me a bit afraid, you know, that you know, what are your thoughts, having probably thought about this much more than the next person?
Well, it kind of comes back a little bit to how we started the conversation in my mind. I think that part of that is because of the way that these substances have been talked about for the last 30, 40 years in most countries around the world. You know, they've they've been labeled as dangerous and harmful, even though the scientific evidence didn't support that designation. And they've been labeled as not having medical value, even though there was actually thousands of studies that were done before they were made illegal, showing that there was potential for medical application. And of course, then even before that, there were, generations of people across a variety of indigenous cultures who were using these substances, long before Western medical providers started exploring them as an adjunct to therapy. So, I think that part of it is that for most of us, we've grown up in a time where these mislabeling of these substances, I think, has really affected our own understanding of what we assume about them. But when you look at the evidence, when you look at the science, it's pretty clear that they are safe, especially when people are properly screened and when they have the right support to help guide the experience and to integrate it afterwards, that there are very few adverse effects, and that across different populations of challenging, oftentimes conditions where there aren't a lot of, success rates or a lot of options for people, that we're seeing that there's a signal of efficacy here, which I think ultimately speaks to, the ubiquitous of how we might be tapping into a transdiagnostic mechanism of healing and growth with this approach that doesn't always exist very cleanly with the treatments that we have currently.
I really like that space around the transdiagnostic sort of model, that we're treating the human, not a category that we place, because we know that there isn't great reliability the moment that you get numerous healthcare workers doing diagnosis. We don't get the consistency that we would like, and so I think transdiagnostic at least allows us to all describe the client's story and situation accurately and collectively. So we do have great reliability, and I think from there we can support someone rather than from a diagnostic set of criteria and thoughts. So I'm a big fan there. One of my last final questions to ask you, as a researcher and obviously, someone who not only looks at this, but does it with quite scientific eyes. Have you had an opportunity to have any sort of psilocybin-assisted support yourself? Is that something that is considered to be useful as part of training? How does that kind of look? How do the universities, explore this side of things, or is it still just very much needs to be with a clinical population or so-called clinical population?
Yes, unfortunately, that is something that, because of the legal status of psilocybin in the US, at least, the option for the providers or the researchers who are doing this work right now to be able to have the treatment themselves really doesn't exist. It could exist if there were funding to pay for it as a part of a study about training clinicians or training individuals who are going to provide this work. And there is some model for that with other treatment modalities. But right now, there hasn't been such a study. So at this point, there hasn't been that opportunity. Oftentimes, the type of things that we're doing to both prepare, obviously it's somewhat of an apprenticeship model at this point. So the research has been going on for about 20 years, and the folks who have trained me, I worked alongside of them for a number of years, learning how to provide this treatment. And the folks that trained them were some of the folks that back in the 50s and 60s were around when it was legal, and they were able to do a lot of this work in a legal structure. And so a lot of it has been this kind of apprenticeship training model since then.
Yeah, fantastic. Where can people go to find out more, whether it's about your work or more broadly around support for drug and alcohol abuse dependence, whether it's around the psilocybin sort of space? Have you got anywhere you can point our listeners to?
Well, you can keep up with what's going on with my work and some of those resources at www.cpdre.org, as well as www.hopkinspsychedelic.org. And either of those websites provide access to kind of what's going on currently at the different research teams that I'm involved with.
And is there any particular piece of research that really stands out for you in terms of what keeps you excited about this space before I let you go?
Well, for me, it's starting to see research that's coming out now that's looking at the therapeutic components, the integration, what's happening after people have these experiences in order for us to dig in and better understand how to be helpful to individuals. In addition to that, we're also now starting to look at short-acting psychedelics that only have acute effects for somewhere between 30 and 40 minutes in order to look at the next wave of what we're going to likely need in order to actually scale this type of treatment to the hundreds of millions of people that need it. A full-day psilocybin session is great. It's also incredibly costly and time-intensive. And so there are shorter-acting psychedelics that can really bring that total effort down, and potentially there's a signal there that they have a therapeutic effect as well. So that's kind of the next thing that's got me excited.
Wow, that does definitely sound exciting, because as you say, accessibility is going to be an issue once approval is provided, whether it's the US, Australia, anywhere around the world, because a day is going to likely exclude a lot of people who don't have that sort of monies and funds, or just the fact of resources. There are not enough clinicians out there to spend a day per person who needs this sort of support. So that sounds wonderful, and I hope that one day both those models are available to everyone, and I wish you the best in the rest of the research, because I think it's definitely something I think that can really assist what we've currently got, particularly in some of those spaces like drug and alcohol, and different trauma work, and like, or maybe it's just only fair to say to help humans, because there's a common thread in all of that. Humans are going through a difficult life, so hopefully we see more of you, more of the research to come as well. So thank you very, very much for today, and all the best. I might have to try and nab you to come back on the show at some point when the research evolves a little bit further.
Well, thank you so much. It was great to meet you.
Thanks. Bye. If you enjoyed this podcast, please support it by going to iTunes and putting a review, subscribe, share it via social media, and tell others about it. Start a conversation. It's listeners like you that make this able and possible, and why we bring in these guests to go out and share their knowledge and resources. And just lastly, if you are a psychologist and you want to go out and be part of a bigger team, develop your experience and get into some exciting work, come to strategicpsychology.com.au/careers and reach out. I'd love to hear from you.